Okay, looks like a nice crowd. Good afternoon, everyone. Welcome to the third session of ARCS Forward and the National Scholar Speaker Series. It's great to see so many faces today. Thanks for being here. Today, we're going to be learning about prostate cancer from three perspectives. September is Prostate Cancer Awareness Month, so we thought it would be a good time to learn more about this all too common cancer. I'm Jill Bray. I'm president of the Phoenix chapter of ARCS Foundation and a member of ARCS Forward. Prior to my time with ARCS, I was a radiation therapist for 22 years, and I treated all kinds of cancer and lots of prostate cancer. This topic is very personal to me as my father passed away from prostate cancer in November of 2020 at the age of 79. So I'm truly honored to be the moderator for this session of our National Scholar Speaker Series, and I'd like to dedicate this session to my dad. Each year, there are about 248,000 new cases of prostate cancer in the United States. And the American Cancer Society states that 1 in 8 men will be diagnosed with prostate cancer during his lifetime. There are also about 34,000 deaths every year in the United States from prostate cancer. Now, the survival rate can be close to 100% for early stage cancers, localized, and even some with regional disease. But if you get into distant disease outside the pelvis, the survival rate drops dramatically to about 30%. Prostate cancer is the most common cancer in American men, so it's important to understand something about it. Unfortunately, most of us will have some encounter with this disease during our lifetime. ARCS Forward is a new initiative of the ARCS Foundation. We started up in May of 2021. We established the National Scholar Speaker Series to inform our audience about science topics that are relevant and interesting to both science and non-science people. We've harnessed talent from across the ARCS Foundation network of 15 chapters. We've been able to put together some terrific Zoom sessions. We had a really good one last month on carbon emissions and offsets with lawn alternatives. We had a great session in May featuring renowned astronomer Dr. Peter Schlerb, who's in our ARCS Alumni Hall of Fame. And we're doing one in November on public health. In case you don't know, ARCS stands for Achievement Rewards for College Scientists. Our mission is to advance science in the United States by providing financial awards to academically outstanding US citizens who are pursuing graduate degrees in science, technology, engineering, and medical research. There's a lot more information about ARCS. If you're interested, see our website, arcsfoundation.org. On behalf of the ARCS Forward Committee, I'd like to thank you for joining us today. Whether you're new to ARCS or a longtime member and supporter, I'm glad you're with us. As you listen to these speakers, please feel free to enter questions into the chat. There'll be time for Q&A at the end. Our session today is going to feature 3 scholars, each with a different perspective and area of research surrounding prostate cancer. First, we're going to hear from Hersh Bhargava from the University of California, San Francisco. Then we're going to hear from Kendra Marr from the University of Arizona, and then from Amy Leatherwood from Oregon Health and Science University. And I want to thank these 3 scholars for giving their time to us and being with us today. So let's get started. Hersh, you want to take it away?
Perfect. Thank you for the introduction. Hopefully in a second, everyone can see this and everyone can hear me. Let me know if not, and I'll go ahead and get started. Good afternoon, or I think it's hopefully afternoon for all of us. Again, my name is Hersh. I'm a third-year PhD candidate in biophysics at UCSF in San Francisco. And today I want to share with you a project of mine relating to trying to use artificial intelligence to improve the way we diagnose and treat prostate cancer, and in particular, alleviate the racial disparity that exists between Black and white patients in prostate cancer through personalized medicine. So to start off with some background on this racial disparity, prostate cancer, unfortunately, has the highest incidence among males of any cancer in the United States, and in addition, has the greatest racial disparity between Black and white patients of any cancer. Black patients experience nearly a 2-fold greater risk of developing the disease and more than a 2-fold greater risk of experiencing disease-related death. This is a disparity that cannot completely be explained by differences in access to care or socioeconomic status. Indeed, current research suggests that there are biological differences in the disease pathogenesis and cancer biology between Black and white patients, which result in this more severe disease in the Black community. However, despite this racial disparity and these biological differences, prostate cancer is currently treated in a race-agnostic fashion. The protocols for diagnosing and treating prostate cancer don't differ between these high versus low risk subsets. So the question motivating my research was, how can we do better, both for the treatment of all prostate cancer patients, but especially with respect to this racial disparity? To understand how we went about improving and developing tools for improving prostate cancer diagnosis and treatment, let me share a little bit of background on how some prostate cancer patients are diagnosed and treated. In particular, I want to emphasize a subset of prostate cancer patients, about 75,000 of them in the United States every year, for whom radical prostatectomy is prescribed as a therapy that's intended to cure these patients of disease. Radical prostatectomy is a surgery in which the prostate is removed, and the goal is to remove the cancer cells along with the prostate and leave the patient cancer-free. Unfortunately, a large fraction of patients who undergo this invasive surgery, more than 1/3, experience recurrence of disease in the days and months following surgery. However, if we could somehow know which of the patients are in this 1/3 category who will experience recurrence, we could prescribe them additional therapies that would reduce their risk of relapse. And we could also spare the remaining 2/3 of patients from having these invasive and aggressive treatments like adjuvant radiation or chemotherapy. So this is where we focused in on trying to improve our ability to predict who are the high-risk patients versus the low-risk patients. Let's take a look at how traditional risk estimation works in prostate cancer. This table you see on the right is what clinicians use to score patients between 0 and 15 with a score that attempts to predict their risk of disease recurrence following surgery. You can see here that a variety of different clinical variables or parameters are taken into account, and depending on the level of certain measurements from the blood of biomarkers, some measurements from the tumor that's removed, and other aspects of the surgery are taken into account to derive a score. Where we in particular wanted to make an improvement was in this specific subset of the score called the pathologic Gleason score. This is something which I'll illustrate a little bit what it is, and then we can see why it needs some improvement. The pathologic Gleason score is determined after prostatectomy when the removed prostate is sectioned and slides are prepared for a pathologist to look at under the microscope, and the pathologist then essentially assigns a score, which is called the Gleason grade or the Gleason score. And the pathologist under the microscope attempts to estimate how disordered the tissue is. We know from many years of cancer biology that more disordered tumors are associated with higher degrees of metastatic tendency and higher degrees aggressiveness in general. So this is sort of a 5-point score, and it's scored as a primary score and a secondary score, where we take into account this information about the structure of the tumor. And depending on how disordered the tumor is, we can try to estimate whether the disease will be aggressive or not. But let's take a look at exactly what the pathologist sees under the microscope when they get these slides. On the left here, we have an image of a prostate quarter mount slide that we scanned under a microscope. And on the right, I've blown up a small inset of the tumor region. And what you can see here is the prostate tissue in writ large and also the tumor subset. And this is what the pathologist looks at and attempts to calculate these scores. But as a computer scientist, the first thing that was striking to me about this approach is that it's highly reductive. There is a huge wealth of information in an image like this. In fact, in this particular image, there's about 24 billion bits of information. And that's being reduced through this process to only 6 bits of information, orders of magnitude of a simplification. So the question we asked is, this Gleason scoring and this approach to treating and developing treatment strategies for prostate cancer has, almost pre-existed modern computing. So now in 2021, can we use computers to take advantage of this image, and this tumor slide information in a more sophisticated way? So what might that look like? Well, what we thought we might want to build is a sort of architecture that looks something like this, where we could take the tumor slide, which is already routinely prepared after radical prostatectomy surgery, scan it under a slide scanning microscope, so we have a digital image just like the one you see on the left here, and then feed this into a computer model that could estimate whether the patient is at high risk of recurrence or low risk of recurrence. And computers have the capability, unlike a pathologist sitting at a microscope, of literally measuring and making complex calculations that are derived from millions of different, or even many millions of different aspects of the tissue structure. So to get into how this could work and exactly what goes on here, let me give you a very simplified lesson in pathology and histology. And I'm by no means a pathologist, but this is pretty much my level of understanding. If we look at this image here, this is what a pathologist would see under the microscope in a specific region of view. And I'll draw your attention to 2 or 3 different things that we can see so you can make a little bit of sense of what we're looking at here. These small purple spheres or little purple circles are nuclei in the tissue, the nucleus of different cells. And you can see those exist throughout, and some of them are more elliptical and some of them are more spherical. The second thing we have are glandular structures. These are these large circular regions or elliptical regions with a white lumen or space inside. And those are, they're critical to how the prostate functions in secreting different substances. And then finally, we have something called the stroma, which is this red, almost diagonally striped or striated regions, which form the parts of the prostate between the glands and other structures. So the question became, pathologists and you and I even can conceptualize of these different aspects of the tissue morphology. And you might even, if you were trained for a little while, like pathologists are through many years of actual education, learn how to perform Gleason scoring yourself, come up with these standardized estimates of tissue disorder. But for a computer to do that is a really hard problem. And we look to a method called deep learning, which has become quite famous in the last few years. And what we did was essentially have pathologists take a pen to these images and manually circle nuclei and stroma and glandular regions, and use that information to teach the computer to recognize the same regions in these images. And you can see here that this actually worked really nicely. In the middle here, here's a deep learning model that was designed for the computer to figure out where the nuclei are. So in white here, this is where the computer thought there were nuclei in this image. And in white on the rightmost image is where the computer thought there were stromal regions, which are these red regions again. And once we got this working effectively, we actually had something that was a much simpler problem. This was really the hard part of getting a computer to understand tissue morphology, because for many years, long before anyone thought about how to even treat prostate cancer, people have been doing geometry. And so once we had this map, which is essentially a bunch of coordinates of where the nuclei are and where the stroma is and where the glands are, we could use years and years of math that people have worked out to measure from this data descriptors of the shape and arrangement and texture and orientation of all of the nuclei, really millions of nuclei and hundreds of thousands of glands and different stromal regions within the tissue. And these metrics have an advantage of being actually measured very precisely. We know exactly what the distances are, what the shapes of different elements of the tissue are. And here you can see sort of a representation of what the computer sees when it looks at these images. And it's really very sophisticated. What we identified, interestingly, in this study is that some of these measurements that we calculated are correlated with the disease aggressiveness. We had patient data sets where we knew how aggressive their disease was, and we found that some of these scores are very much associated with high risk or low risk of cancer recurrence after surgery. That enabled us to feed this information into computerized models, which are actually machine learning models, and train computers to look at these measurements, computer-derived measurements of tissue morphology, and predict patient risk. And this is where we found really probably the most interesting finding of this study, which is that when we train models that were specific to Black or white patients, the population-specific models dramatically outperformed models that were trained in a population non-specific fashion. And this strongly supports the need for personalized medicine models that take into account things like genetic origin or background, especially in cases where we have diseases that have a strong component of population-specific disease biology. It turned out that the models that we developed, and this is just sort of the general architecture, but these models turned out to outperform the current clinical standards for Black in the Black patient data sets of this study, and perform nearly on par with the current clinical standards for white patients. We essentially published these results in clinical cancer research earlier in the pandemic, and have filed for a patent for this technology, such that we hope that one day we could leverage these algorithms to actually predict risk for patients who have undergone radical prostatectomy, and clinicians are trying to decide whether or not to prescribe further lines of therapy. With that, I'd like to thank my collaborators on this study. This was an effort from many different institutions, with collaborators spanning from biostatistics to biophysics to computer science to oncologists and pathologists. I'd finally and importantly like to thank the ARCS Foundation, of course, for supporting this work, Jill and everyone for coordinating this event and inviting me to speak, and my fellow speakers as well for taking the time today to discuss this most important disease. Thank you very much.
Thanks, Hersh. That was fascinating. I've always heard about the differences in African-American men versus white men, and to see that proof of that on the slides and to see how that's playing out in real life is fascinating. Thank you for that. Kendra, what can you tell us?
Thank you so much, Jill, and thanks for the great talk, Hersh. You introduced us really well to the concept of prostate cancer and some of the issues that we're facing in the research realm and understanding this disease. So I'll tell you a little bit about some of my work in prostate cancer invasion through the smooth muscle capsule of the prostate. And first of all, I can introduce myself. My name is Kendra, and I'm an MD PhD candidate. So I've done 2 years of medical school, and now I'm in the 4th year of my PhD studies in Dr. Ann Kress's lab at the University of Arizona College of Medicine, Tucson. Now, why am I looking at muscle invasion? Why are we interested in muscle invasive cancer? Well, most solid tumors, when they're organ confined, they're not lethal with treatment, but they become lethal when they escape the primary organ or the primary site in which they started. And then once they escape, they metastasize or spread to other sites. And that's most of the time when they become lethal, as Jill alluded to in her introduction earlier. And now smooth muscle invasion is a principal means of escape for a lot of tumors from their original site. So a lot of tumors that arise in organs are covered in smooth muscle. So they have to invade through the smooth muscle to escape the organ. Or the cancer cells can get into the blood supply and they have to invade into and out of the smooth muscle layer that surrounds the blood vessels in order to get to the stem sites. And many cancers, including the ones listed here, and I'll talk about prostate today, invade the surrounding muscle, but the mechanisms of this are largely unexplored. We don't know why some cancers invade through muscle and why some do not. And as an MD PhD student, I'm really driven by this unmet clinical need in prostate cancer, specifically that there's a substantial degree of overdiagnosis. And what that means is a lot of prostate a lot of patients are diagnosed with prostate cancer and treated when maybe their tumor was slow growing and was never going to cause them any symptoms, but we treat them anyway because we need to better identify patients who require aggressive therapy, so whose cancer is going to become aggressive and become dangerous to their life, versus those who may not need any therapy at all. And now the prostate gland is composed of a fibromuscular stroma. So we have the glands surrounded by the stroma that's fibrous and muscular. And surrounding the gland, which is in gray on this cartoon on the right, is a capsule made of smooth muscle. Now these aggressive tumors, as they grow larger, they begin to invade through the smooth muscle capsule and get out of the prostate gland to go to other sites. And they often do this along nerves. This is a process called extracapsular extension. And here's a histology section on the right kind of showing that. So we have tumor cells in purple kind of coming right up against this layer of muscle, which is in pink. And then there's some fat cells outside of the prostate. You even have some cancer in the periprostatic fat here, which is diagnostic of extracapsular extension. And so I really want to know, why do some cancers invade through this muscle layer and escape to distant sites? And how does that happen? Even once it escapes the prostate, it has to invade through, or it can invade through the muscle of nearby organs. So here's a cross section of the male pelvis. So here's the bladder, and the prostate lays at the base of the bladder. So here's a prostate tumor that's invading into the muscle of the bladder wall and the muscle of the seminal vesicle here, and even through the muscle surrounding the colon. So it can invade through distant sites by invading through the muscle. And all of these muscle invasive events put prostate cancer automatically at high or very high risk for progression or recurrence. But this can be difficult to detect. We don't have good biomarkers to predict whose cancer is going to be muscle invasive and whose isn't. And so I hypothesize that the smooth muscle invasion confers aggressive behavior of these prostate cancer cells and increases their metastatic behavior. And so I employ some laboratory models to understand smooth muscle invasion as a prerequisite of metastasis. And we hope that we can further define the molecular characteristics of this aggressive behavior to improve the staging and treatment of our patients. And now this is the muscle invasion model that I use a lot in lab. We use other ones, but this one's a mouse model. So here we take some mice and we inject prostate cancer cells into the intraperitoneal cavity. So this is their like abdominal cavity. And over the course of 6 to 8 weeks, the prostate cancer cells will form tumors on the inferior surface of the diaphragm, so the bottom surface here, and they'll invade through the muscle of the diaphragm. So it's those purple cells invading through the pink muscle of the diaphragm. And some of them will actually completely go through the muscle of the diaphragm and reach the superior surface. So these are ones that have completely crossed the muscle barrier. Here's a histology section of what that looks like. So anything below this dotted line is the primary tumor that's sitting on the surface of the diaphragm. And then these pink cells are the muscle cells that are being disrupted by the tumor as it invades through the muscle. And we even have a tumor up here on the superior surface. So these cells have gone all the way through the muscle. If we count how many invasion sites there are and the depth of the invasion, we can actually use genetic tools such as CRISPR to modulate this behavior. And here, I won't go too much into the data, but here, for example, we've knocked out a certain cell adhesion molecule or mutated it to prevent these cells from doing that. So we have really good mouse tools to investigate this. And another thing that's interesting about this model to us is that muscle is a very common barrier to invasion in a lot of different cancer types, like I alluded to earlier, but it's almost never a metastatic destination. When cancer metastasizes, it doesn't usually go to muscle. In prostate cancer, for example, it really likes to go to the bone. That's one of the most common metastatic destinations. So I want to know, how do these tumor cells change in the specialized microenvironment of the muscle? And could these changes that we see serve as useful biomarkers for aggressive disease so that we can predict whose cancer is going to behave aggressively and whose isn't. And furthermore, can these cells be specifically targeted so that we can get rid of the aggressive and invasive cells to improve the treatment of prostate cancer? So one way I've done this is to isolate this subpopulation of cells from the superior diaphragm surface. So to remind you, these are the cells that have completely crossed the muscle of the diaphragm. And I put those back in a dish and grow them up before injecting them back into mice and redoing the whole process. So basically these cells have invaded through the muscle of the diaphragm 3 times in order to get a final cell line out of it that we think will be aggressive. And so these cancer cells that have traversed the elastic muscle, I think that they're now going to be primed for distant metastasis. I think they're going to behave more aggressively. And we think that the cells that invade the muscle will have different drug sensitivity as well. And we do to our, our excitement, see some aggressive cell behavior when we do this. So 2 of these lines, we call them KM lines, produced metastatic lesions to the tibia and the femur. And it's important to note that the original cell line that I injected into these mice will not form bone metastases. So these cells only form bone metastases after they've invaded through a muscle layer. And you can see them on histology. This is the outline of the bone on histology, and this is the growth plate. And then inside the bone, we have immature red and white blood cells. And then here, this purple part is the tumor. You can see it better when we stain for a different protein called pan-cytokeratin. The cytokeratin stains epithelial cells, such as the prostate cancer cells. Also, 2 of these lines showed increased resistance to a chemotherapeutic drug called Taxotere. This is called a dose response curve. So we see the viability of cells on the y-axis plotted next to the dose of Taxotere that we gave the cells. In black is the parental cell line, so the one that has not invaded the muscle. And so it has this dose response curve. One of these ones, the pink one, it has the most striking change. This is KM3J7. You see that as we increase the dose of Taxotere, these cells are still almost 100% viable, whereas the parent line is dropped to only 50%. So this is showing an increased resistance to chemotherapeutic drugs. That's just a little bit of data and a little taste of some of the research I've been working on in the past 4 years, but this research has really broad implications to us to prevent known overtreatment of prostate cancer so that we can better choose which patients to, just watchful waiting on their cancer versus patients who need definitive therapy. And hopefully we can work to block the metastatic cascade at its early stage. So again, understanding why some of these tumors that arise in the prostate now begin to invade through the muscle and extend outside of the prostate. And I have a lot of people to acknowledge my lab. The PI of my lab is Dr. Ann Kress, and all of my current and former lab mates, funding, my committee members, and then we work with a lot of core facilities to help make this possible, and then my medical colleagues as well. Big thanks to the ARCS Foundation and ARCS Forward for supporting me in my training and supporting this research. This is, it's really generous support that the ARCS program gives to us, and I think like having the support of the ARCS Foundation makes me feel like there's a lot of weight off my shoulders, and so I can focus on my passions and focus on my research. And I hope that I can pay this forward in the future of my career. Thank you.
Thanks, Kendra. We're happy to support you. I speak on behalf of the Phoenix chapter. We're so proud of the work that you do. And I know Libby Worsley Crouch is tremendously pleased to be your donor. Thank you. Now let's hear from Amy Leatherwood. Amy, what have you been up to?
Hi, everyone. Can you hear me okay?
Yeah.
Thank you very much, Hersh and Kendra, for that wonderful introduction. Good afternoon. My name's Amy Leatherwood. I'm actually more at the beginning of my research than they are, so you'll be hearing about what I'm planning to do. I'm beginning my 4th year of PhD studies at Oregon Health and Science University in Portland. And I'm delighted to be here to talk to you today about my area of interest. And you know what, hold on just a moment. There we go. I had to move something on my screen for a moment. I'd also like to acknowledge the amazing support I've received from the ARCS Foundation, particularly the Oregon chapter where I live and attend school, and my sponsors, Kate Joseph and Tom Murray. I would also like to express thanks to my dissertation chair, Dr. Lisi Hansen, for her thoughtful and unwavering guidance on my journey. My research is focused on understanding the relationship between cognitive function and the return to work experience in men who have received hormone ablation therapy, along with radiation to cure their prostate cancer. I'm interested in outcomes for cancer survivors, so I'm studying cancer survivorship. I have no disclosures, just my disclosure slide here. A little background, in addition to living the PhD student life, I'm also a nurse practitioner. I practiced for 18 years. I became interested in cancer survivorship and outcomes research when I was tasked with starting up a cancer survivorship clinic in the Department of Radiation Oncology at OHSU 9 years ago. I didn't know much about the side effects faced by survivors after treatment, and I needed to educate myself on both cancer treatments and their short and long-term side effects. What I did learn was that for each cancer survivor, it's a process, physical, mental, and spiritual, to come to terms with the loss of one's life before cancer, and then to embrace the idea of becoming a cancer survivor. I also learned that although there are side effects from treatment that are more obvious and physical, such as urinary issues, changes in body appearance, loss of hair, radiation burns, that take some time to heal, it's often the intangible side effects, such as the inability to accept a new body image, depression over concerns about cancer returning, and frustration or fear about facing a world that now seems daunting when you have cognitive function loss from chemotherapy or hormone treatments. I found that these intangible side effects were not well studied, but absolutely have an impact on quality of life after cancer. The need for more knowledge about how to help a patient transition to a functional cancer survivor seemed more important than ever to me. And it was this motivation that inspired me to continue studying for a doctorate degree in hopes that I could involve myself more in the research that would lead to future improvements in survivorship care. Now that I've given a little bit of background on myself and how I came to be here talking to you today, I'll dive into the topic I'm exploring, which is how do cognitive changes from hormone treatment for prostate cancer affect the return to work experience. In 2018, you will hear a few familiar sounding statistics, I think, here. In 2018, there were an estimated 18.1 million new cases of cancer worldwide and 9.6 million deaths. We are seeing that cancer prevalence and mortality rates have been rising around the world. The reasons for this vary, but they might be a reflection of both population growth and an aging of the population. Around the world, the top cancer types diagnosed include breast, prostate, colon, liver, and lung cancers. In men, prostate cancer is the most frequently diagnosed cancer, and after lung cancer, it's also the #2 cause of cancer-related death. Prostate cancer is the second leading cause of cancer death overall in the United States, which corresponds well with what we're seeing globally. 1 in 8 men, as Jill mentioned before, will be diagnosed with prostate cancer in his lifetime here, and about 1 in 41 will die from it. Notably, the prevalence of prostate cancer is nearly 60% higher in Blacks than in whites in the United States, as Hersh mentioned. The reason why is not known, but explanations for this disparity tend to revolve around influences from the community, environment and genetics. So that's kind of pointing towards his work there. The good news about prostate cancer is that it also has one of the highest survivor rates, and these men represent a large percentage of overall cancer survivors. This is partially due to improved screening and detection of the cancer and better and early treatments, but it's also related to the slow growing nature of this type of cancer. The majority of prostate cancers are lower grade, meaning that they're less aggressive, and many men are diagnosed after the age of 65. In fact, when prostate cancer is detected at an early stage, as Jill mentioned, before it's spread outside of the gland, and you can see that here in the green box, the 5-year survival rate in the United States is around 98%. This high survival rate means that many men will be looking forward to resuming life in their new normal as a cancer survivor. For clinicians caring for these survivors, it means that it's even more important to identify roadblocks to recovery, including long-term side effects, such as urinary and sexual dysfunction, memory issues, depression, and other changes that are caused by treatment. Radiation with concurrent androgen deprivation therapy, or ADT, is a commonly used first-line treatment for prostate cancer, especially for men who do not wish to have an invasive procedure such as surgery or prostatectomy that I think Hersh was mentioning that in his discussion. Why are radiation and ADT used together? This graph is taken from data from a retrospective 2019 study conducted by Amit et al. Of 373 intermediate risk prostate cancer patients who were treated with definitive radiation and some with radiation plus ADT. For low-grade and early-stage prostate cancer, such as stages 1 or 2 that I mentioned previously, the combination treatment of radiation with androgen deprivation can improve overall survival and tumor control better than just ADT alone. And you can see from the graph here that specifically in younger men under age 70, the relapse-free survival rate is significantly improved with both radiation and ADT versus ADT alone. These types of results have led to a standardization of ADT being given to prostate cancer patients who are receiving radiation. Side effects. So the side effects from ADT are global, and they can potentially have more impacts on daily life. They can include erectile dysfunction and loss of libido, impacting self-confidence and relationships, excessive growth of breast tissue, hot flashes, loss of muscle mass leading to early frailty, weight gain and fatigue, which can make regular exercise and activity more difficult, and also leads to other systemic comorbidities such as diabetes or high blood pressure, an increased risk for osteoporosis. And finally, temporary cognitive impairment can be seen in men starting at 6 to 12 months after initiation of ADT treatment. This interferes even further with the process of getting back to a normal life after cancer. I'd like to talk now about the last side effect I mentioned, which is cognitive impairment, also sometimes termed cognitive decline. According to the CDC, cognitive impairment is when a person has trouble remembering, learning new things, concentrating, or making decisions that affect their everyday life. We know from studies of men with and without prostate cancer that lower levels of testosterone play a role in aging and the brain, and it can negatively affect cognitive function. Men who are receiving ADT as a part of their cancer treatment face a rapid drop of their testosterone levels, which could cause noticeable decline in cognitive function. Studies looking at the effects of ADT on cognition have noted decreases in the areas of working memory, verbal memory, and visuospatial memory. This can reveal itself through problems with multitasking, a lack of focus and attention, and then decreased ability to concentrate when performing tasks. So how do cognitive changes affect us? Loss of cognitive ability, even if for a limited time, and especially during a crucial period of recovery and transition to cancer survivorship, can prove detrimental. Relationships are strained with new emotions of frustration, helplessness, and worry, both on the part of the survivor and perhaps a partner or a child. Self-awareness about cognitive performance can lead to a loss of self-confidence and subsequent isolation from interaction with others, and even potentially cycle into depression or anxiety. What about employment? Worries and concerns about personal cognitive performance can also make it difficult for an active and previously employed cancer patient to return to work after treatment. This can lead to even more distress about personal economic stability, causing more anxiety and burden during the recovery period. So why is the effect of cognitive change on employment such a big deal? Over the past decade, the working age in the United States has steadily increased. The rate of employment for Americans aged 75 or older is at its highest level since 2009. The Census Bureau further projects that by the year 2024, 13 million people aged 65 and older will still be working in the United States. These seniors will represent the fastest growing sector of the workforce from 2014 to 2024. Stability, and by this I mean economic stability. People are living healthier and longer. They need to consider how they will support themselves in the long term. Additionally, due to years of stagnant wages and a shift away from traditional pensions, many Americans will find themselves needing to work as long as they can. Normality and identity. Cancer survivors are looking to find their new normal after treatment. At least one study by Grunfeld et al. Has found a close tie between working and self-identity, which makes us aware that the act of returning to work after cancer treatment is key in helping the survivor to keep their identity as a worker and start the return to a normal life. Identity with work has also been found to be of great importance, in particular to males, and to lose that ability to return in a timely manner might feel like a loss of self to them. This leads me into the topic of workability, which I will briefly define for you. Workability is defined as a holistic concept that refers to people's ability to do their work in a healthy and productive way, given the balance between a person's resources, including their health and functional abilities, education and competence, and values and attitudes, and their work demands. The concept of workability is crucial for many disciplines, particularly in fields related to working life and to reintegration into work life. It helps to standardize professional activities by defining skills and activities typically belonging to different classes of work and identifying what an employee can be expected to do and within which context it should be done. Thanks to tools that are able to measure workability, we're able to get a sense of how individuals perceive their ability or inability to do work and how they feel they're being perceived by others in their abilities to work. We know that cognitive impairment includes changes in cognitive ability from baseline, and that due to side effects from ADT, prostate cancer survivors are experiencing these at a crucial period of time when they're expected to return to work. This is what I'll be studying over the next year with a mixed methods approach. What is the role of cognitive change on workability and the experience of returning to work after prostate cancer? Findings from this study may help to inform us about challenges related to cognition and work and help us understand how we can best support cancer survivors during the transition back to work. My hope is that this can be addressed at the clinical level, at the occupational health level, and at the policymaking level. I believe that the more that we are able to understand about the experience of survivors, the more tailored our care can be and the better our anticipatory guidance is for helping patients find their new normal after cancer. I thank you all for coming to listen to our presentations and perspectives on prostate cancer today during Prostate Cancer Awareness Month. A special thank you to the ARCS Forward group for inviting us all to speak. My scholarly work has been generously supported by an ARCS Foundation scholarship and an OHSU Dean scholarship. I look forward to sharing my findings with you in the future. Thank you very much.
Thanks, Amy. Very interesting. What you didn't say, but what I will say after 22 years in radiation oncology is that the problems that you spoke about, of course, are happening to men because they are the ones that have prostate cancer. And it is particularly hard for them to talk about these things.
Exactly.
Very challenging. Very,
I did not say that. And yes, thank you for pointing that out. It's so true.
I just always found that to be a real challenge. It was very interesting treating women. They would tell me everything. The men told me nothing. I was always grateful that I had a basic knowledge of sports and we could always talk about that. And that was sometimes a way to open the door, and then we could sometimes get to a deeper, more clinical subject, but it's very hard for men to discuss these things.
Very true. Very true. Thank you.
Yeah, thanks. All of you guys, great information, so important. We did have a question come in for Hersh. The question is, can you analyze the images from a biopsy or only after prostatectomy when you're trying to assess and understand reoccurrence chances before surgery? Does the biopsy alone give you enough information?
That's a great question. And so we are actually working on sort of models that are specifically designed to work with biopsy data. But because the needle biopsies are so small, there's such a small amount of tissue present, it is often, and this is something that also pathologists can be limited by, but you don't have nearly as large of a field of view of the tissue. And sometimes there's not enough information to make as robust or highly certain decisions. But certainly, you know, we are thinking about how we can use biopsy data, perhaps in conjunction with blood biomarker data, or perhaps different stains or immunohistochemistry to augment that certainty and then have a less invasive way of using these models to make highly useful decisions. Good question.
Thank you. I have a question for, well, really any one of you could field it, but Kendra touched on it a little bit, the concept of watchful waiting that comes up in the clinic. And it used to be, there was not always a lot of really good information to tell someone whether or not they should adopt the watchful waiting approach, which is basically, you know, let me see where my PSA goes, let me see if I should take treatment or not. And it was a very hard decision for patients to make if they should pursue that or not. Has that gotten easier for a patient to decide that they're going to do watchful waiting or take treatment, or is it still sort of confusing?
Yeah, that's a great question. I'm not yet in the clinic, so I don't have so much that one-on-one experience with the patients, but I don't think having to choose between watchful waiting and treatment is ever going to be an easy decision for anybody. I mean, the concept of it is that I mentioned earlier that there's a lot of overdiagnosis with prostate cancer, meaning that, you know, a lot of prostate cancers grow so slowly that it doesn't impact survival, but we find it anyway, and sometimes we don't really know what to do with it. So we can offer the patients this therapy, you know, the side effects and long-term consequences of which were very nicely reviewed by Amy, or we do watchful waiting where, you know, we check periodically their PSA levels, see if they continue to increase or if they do become symptomatic. But yeah, so I think that has gone up. Like historically, it has gone up because, you know, with the advent of PSA testing and screening, you know, at first we were screening lots of men for prostate cancer. And so we were diagnosing lots of prostate cancer. And that's when we started to learn that we're diagnosing a lot more prostate cancer than is becoming symptomatic. And so that's kind of where the concept of watchful waiting came in. And that's a lot of what my research is trying to address.
Thank you. Amy, we have a question for you. How many men would you say refuse treatment after hearing these kind of serious effects that you're talking about? I mean, that's a little daunting.
It's a little, yeah, it is a little daunting. Refused treatment. I would say that there were, so, and you come from radiation background as well. So they do have the choice of radiation alone versus radiation plus ADT. Mm-hmm. Radiation on its own has side effects, as you know. So they're still probably going to get some of the urinary, you know, and sexual dysfunction side effects from just the radiation, really. And then of course ADT, you add that on, and that just kind of really, I would say, you know, it makes some more side effects for them to deal with. So I do recall that there were, you know, not a huge subset, but there were some patients where once they heard about the side effects, they might have stepped away more from ADT and said, well, I'll take my chances with radiation alone, mm-hmm. and have gone that route. But in the end, and those are people that have entirely stepped away from the idea of a prostatectomy, which is the full surgery. So that felt daunting to them. Mm-hmm. So I wouldn't say, I don't think it was a large amount, but I think I can recall some that had said, you know, like maybe I'll just go with the radiation alone versus radiation plus ADT treatment, mm-hmm. which is, you know, in general is supposed to improve their outcomes if they have a higher grade of cancer. So they're coming with a higher grade. Did that answer the question? I hope.
Yeah.
Okay.
Can you guys talk about the PSA? I guess it's still the gold standard for, diagnosing prostate cancer initially and sort of measuring its aggressiveness, but it's not without its flaws. What's the latest thinking on PSA?
I was looking at, I could speak a little to PSA in that, we really used it. PSA, there are certain certain marks or levels within age groups, right, that are considered to be a norm. However, when we're looking at whether or not we need to go ahead and biopsy someone for prostate cancer, we are looking at a PSA trend at that point. We are like, what is, and this is where it's really important to maybe, to have a baseline PSA starting from an earlier age if we can, especially in those patients at high risk with a family history of prostate cancer. But having that baseline PSA is really important because we're watching how it's trending to see whether we're going to push the button and say, okay, let's think about getting a biopsy.
What age do you get that baseline PSA typically?
So it depends upon whether there's a family history of prostate cancer. I want to say it's 10, if one had a family member diagnosed early, first line family member like father, say at age 60, they would definitely, you definitely want to be screening by age 50, but they had age 50 as a baseline for screening anyway. So that was not a good number to give you as a example, say earlier than that, but it's 10 years, be like 10 years earlier than the age at which your relative was diagnosed.
Okay.
And then maybe, I don't know if the others had looked more into the current PSA.
Yeah, I have the American Urological Association guidelines for PSA testing. It's a little bit, right, first of all, I'm not a medical provider, so I can't provide, any diagnostic information or anything like that. But, according to the American Urological Association, they have panels of healthcare professionals who review the evidence for PSA testing, because any type of cancer screening tool that we adopt, it needs to really show that it's effective in decreasing the mortality of cancer. And PSA has been a little bit of a struggle because, like we've said over and over again, prostate cancer is very often a slow growing disease. So in a lot of age groups, there hasn't been shown very strong benefit to PSA testing. And again, this is population studies, so it doesn't replace an individual recommendation. I think the strongest evidence they have so far is for men between ages 55 and 69. And, it's supposed to be a shared decision-making process, a conversation with your healthcare professional about, risks and benefits of PSA screening, your personal and family history and whether or not that will be, advantageous to you as a patient.
Mm-hmm.
But I saw someone also asked, like, if it is, Jill mentioned that it's not the best screening tool because it can be a false positive sometimes. PSA can go up for a lot of different reasons, not just cancer, and Amy mentioned this too, and it makes it a little more difficult to decide whether or not to go ahead and biopsy. I did want to add, I have another research project that I didn't present today looking at prostatic MRI. So this is being used more and more often in the clinical setting. So you can do kind of a high resolution, what's called a multi-parametric MRI of the prostate. And there the radiologist can see lesions within the prostate. And there's more and more research going on in that to, see if we can look at those lesions on MRI and determine whether or not they're likely to be prostate cancer. And then that can also help our decision whether to biopsy or where to collect the biopsies from.
Interesting. We had a question from somebody about the use of seed implants as treatment. Do you have thoughts on that? I know that's typically a treatment for an early stage prostate cancer, which we haven't talked about as much, but do you have any thoughts on that? Anybody? We were hopeful.
Don't really have thoughts. I'm not a medical provider yet, but for those who may not know, Amy brought up that radiation therapy, and Jill also brought up that radiation therapy is commonly used as a curative treatment for prostate cancer. And this can be often done in one of two ways. One would be external beam radiation, where they use X-rays or protons from outside the body and aim them at the prostate gland to deliver a high dose of radiation to the prostate. You can also use beads. So these are like little radioactive beads that are injected directly into the prostate. So it helps decrease the dosage of radiation to surrounding organs to kind of like concentrate it in the prostate. And I'm not sure, but I believe it's also considered a curative treatment. But I think you're right in that it's mostly for low grade, but don't quote me on that.
It's usually for really small, very localized tumors, pretty early stage, usually if you hear of a person who's been able to get seeds, they usually have a really favorable outcome. And it's usually pretty well tolerated, not as many side effects. Just a note to all of you, Roger Wilson says, thank you all. Very helpful for me personally. Will be great conversation for my next dinner party with my fellow old men. So Roger, I don't know what kind of parties you're throwing, but they sound interesting. Let's see what other questions we have here. Kendra, where'd it go? How do you know if the prostate cancer is not spreading via vessels and or lymphatics that transverse the muscle barrier?
Oh, how do we know if it's not doing that?
Right.
So I'm interpreting this question as how do we know it is localized versus it's spreading?
I think so. I read it as is, but that's how I would take it.
Yeah. So there's a couple ways to do that. We alluded to the fact that if a patient is going for prostate biopsy, they have maybe an MRI finding or increased PSA or something to indicate that, we can look on biopsy and some evidence we see of the cancer starting to invade via the nerves and vessels. We can see what's called perineural invasion on biopsy, where the cancer actually surrounds a nerve. And that's been shown in many publications to be the primary way that it escapes the gland. It's hard to know when something's not happening, because just because we don't see it doesn't mean it's not happening. And so that's actually a big goal of my research. You can sometimes see extraprostatic extension on MRI, but it's typically when it's pretty frank, like we can see that it's already started to go outside the prostate, but you can't see it molecularly, like on a cellular level, just because we can't see that small on MRI. So I'm hoping that by, doing these studies on the muscle invasive cancers, that maybe we can find maybe a serum marker or gene that we know is starting to go up when these cells become invasive and are starting to invade through the muscle. So I hope they answered your question.
It is really interesting that it passes through muscle but doesn't stay there. That's
yeah, I know it's really fascinating to us, and lots of cancers do it.
Yeah. Well, this was absolutely fascinating. The research you guys are doing is just amazing. Just really grateful to you for participating today. Thank you so much. Our next session is going to be November 9th, and we're going to talk about public health. So I hope you'll join us for that. Every time we gather, we are pulling from our network of 15 ARCS chapters. So we have different scholars presenting on different topics. So it's been really fun getting to work with you guys on the session and hear more about what you're doing. So it's exciting. So I look forward to the next time. As always, you can look at arcsfoundation.org for more information on ARCS, and we'll send out a link of today's the recording of today's session, along with a survey with a couple simple questions. Please let us know what topics you want to hear about. We really do listen. A lot of these topics that we're looking at have been chosen because people have filled out the surveys and told us what they wanted to learn about, and we do our best to find scholars working in those areas. So let us know, and hopefully we'll see you November 9th to learn about public health. And Hersh, Amy, Kendra, thank you so much. Wishing you all the best with the rest of your academic careers and beyond. Thank you very much.
Thank you, and thank you everyone for listening.
Thank you very much.
Thank you all.
Bye, everyone.